It's working. So, good evening, ladies and gentlemen. This is going to be the second edition of House on Fire. For those who are new to it, just to give you a brief introduction, this session is actually a debate session. There's nothing special about it, but instead of a motion, they're given a situation. That's the first uniquity, so to speak, of the session. And the other is the participants have to be more than just friends or acquaintances. So they are spouses. They are married and tied knots with each other, but still they are going to fight publicly on the stage. So where, of course, they don't have the don't have access to their typical instruments like the balance and the utensils and the vessels, but still they would have their words to fight with. So just like houses are not basically made out of stones or bricks or cement or sand, as they say, house is made up of emotions, of people. Similarly, a fire doesn't have to be conjured by a spark happening somewhere. A fire can also arise from words, and it can really rise up high, a few meters. And the one who actually ignites that obviously has to be the stupid Cupid who doesn't fire arrows, rather fires firecrackers at the couples, and that role, fortunately or unfortunately, has been bestowed upon me time after time. So, welcome you all to this unique session titled House on Fire. We have 3 couples, all of them being ophthalmologists. Before we proceed, I'll just outline briefly what are the rules of this debate. Each situation has been given to them prior hand, and they'll obviously come prepared with it. They would have 5 minutes to speak on, 5 minutes to speak on, each of them. So that will consume 10 minutes per motion or per situation. And then they'll have a minute's rebuttal, wherein each participant would be free to ask a question to the opponent or the spouse based on what he or she has just presented. And then 1 minute for the other participant to respond to the query that has been raised by the husband or the wife, as the case may be. We don't have panelists. I intentionally did not keep panelists because all of you would be a panelist. All of you would be free to raise a hand and ask a question at the end of it to either one of them. And then we would decide combinedly whether the XX or the XY, who made it large and who actually succeeded in overcoming and overshadowing the other genotype. Are we clear on that? Yes. Brilliant. So the first couple who have very gracefully accepted our invitation to be a part of this are from Kolkata, Dr. Debashish and Dr. Mrs. Maitrey Das. Here is the situation for them. Listen to it carefully. The situation is a 52-year-old lady, a 52-year-old lady who has a grade 2 cataract, a measured IOP of 20 on Goldman's applanation tonometer, occludable angles on gonioscopy, and normal fields. I repeat, grade 2 cataract, measured IOP of 20 on GAT, occludable angles, and normal fields. The modality I choose would be, Dr. Debashish would be speaking on cataract surgery and then evaluate the angles and treat accordingly if needed. Dr. Maitrey counters him saying, I'll do a laser PI first to treat the angle, bring down the IOP, and then do cataract surgery. So this is what they are fighting on. Dr. Debashish, you lead, and Dr. Maitrey to follow. All yours, sir. We don't have a timer. Take your time, but stick to 5 minutes. Not necessarily. Not necessarily.
She will have the last word always. Whether he starts first will save the grace.
I strongly disagree to that.
Personal experience?
Absolutely. More than once.
First one. Thank you so much, Dr. Anurag. So with that, we start off with the first round of the debate. The modality is, I will be speaking for cataract surgery first and treat the glaucomatous condition thereafter. Let us judge the premises. A 52-year-old lady, grade 2 cataract, applanation tonometry 20 millimeters of mercury, gonioscopy shows occludable angles, and fields are normal. Let us get the definition first. Primary angle closure suspect is a patient with a 180 degrees or more of iridotrabecular contact. The IOP is normal. There is no peripheral anterior synechia and no optic nerve damage. And the management for PACS is, we must remember, most patients won't progress to PAC or PACG. So the option 1 is laser iridotomy to prevent progression. And option 2 is to observe the progressive narrowing or PAS, which is, of course, a warning sign for acute anterior chamber congestion. Laser is preferred if on medications that may cause a pupillary block, or there are symptoms of past angle closure, or the patient has a follow-up difficulty. We must remember laser leads to increased cataract formation and even increased IOP. So with a patient with a significant cataract and PSCS or PSC, the best treatment modality is early lens extraction. In cataract surgery in patients with closed angles, the IOP lowering is proportional to the preoperative IOP and the resultant angle widening. And patients with the narrowest angles preoperative benefit the most from the cataract extraction, provided the angle has not become permanently closed with PAS. So it anatomically makes sense. I would like to go through a little different studies. The Eagle study has shown, I want to highlight the yellow, I've already highlighted the yellow portion. I will just highlight the yellow portion. In the Eagle study, they have said clear lens extraction showed greater efficacy and was more cost effective than laser peripheral iridotomy and should be considered as an option for the first line of treatment. That's the Eagle study. In iJournal, in the review article, it said, the trial showed clear lens extraction to be superior to peripheral iridotomy, both for IOP control and patients' reported quality of life. On these grounds, clear lens extraction should be considered for the first line treatment of more advanced angle closure diseases. Moving over to the Graves Archives of Ophthalmology, let me go to the conclusion. Compared with LPI, peripheral iridectomy, clear lens extraction resulted in a wider anterior chamber angle, a deeper anterior chamber, and a lower IOP in the PSCS eyes. Moreover, no residual angle closure was observed after lens extraction, which could morphologically prevent the progression of the angle closure. Eye sciences. Cataract or clear lens extraction has been suggested as a treatment option for different spectrums of primary angle closure disease. It might reduce the risk of progression of angle closure and or glaucoma by helping to open the angle and control the intraocular pressure. And recent randomized controlled trials have demonstrated greater promise of phacoemulsification cataract surgery alone for control of IOP. Mind it. From the Survey of Ophthalmology, the crystalline lens plays an important role in the pathophysiology of primary angle closure and primary angle closure glaucoma. The aging process is associated with a progressive enlargement of the lens. Recently, clear lens phacoemulsification has been suggested as a treatment modality in such eyes. So the last literature survey in the prevalence and breakdown of narrow angle anterior chamber angle pathology by Nikhil Jain, he also said the majority of these are at a relatively lower risk of developing acute and chronic angle closure glaucoma. And of the remaining patients, only 8% have primary angle closure suspect or primary angle closure glaucoma, and thus we can avoid this. So the debate is, what would you like to treat? The occludable angles of a cataractous lady or a lady with a reduced vision due to cataract? I conclude by saying, let us treat the patient as a whole and not chase the signs the patient has. Thank you.
Not mentioned.
Expected to. Does it? You agree?
No, no,
With
when
the
the
fields-
fields are normal,
Okay, let's assume the field was 0.5. Let's see the CDR was 0.5. Would it change? Okay. The vision, there is grade 2 cataract. Expectedly, it was not 6.6. No, we are not discussing. She just raised a point. She's just raised a point and tried to hammer the moderator that you have not supplied with one essential or valid point. So, Maitreya ma'am, he quoted a few literatures which are generally searched only by a glaucomatologist. Did he take the help of a competitor glaucomatologist to find out and prove his point on that count, or?
Should I?
no, my data was given by Manish and not Maitri.
That is what I said, a competitor glaucomatologist and not her.
Okay, thank you so much for giving me this topic. So he has set the house on fire. Okay? And I have to tackle. So this case has already been told you that grade 2 cataract, measured IOP20 on GAT, that's a snapshot only. Occludable angles on gonioscopy minded, and normal fields. So modality I like to choose is laser PI to treat the angle first, bring the pressure down, make the patient comfortable, and plan cataract surgery. I think it makes a sense. Thank you very much, Dr. Mishra, for giving this opportunity, because I don't have to fight much for this case. This is a standard treatment everyone knows. I felt funny, to come to the stage to prove something which has already been proven. So my slides are meant for the adults and not for the adults who behave like a child. So he's a 52-year-old lady having cataract, pressure is 20, angle is occludable. Why he is not dealing the angle, I don't understand. Angle is occludable. I don't know, I don't think so that he knows the meaning of occludability of the angle. So, my goodness, angle is, if it is occludable, see, it behaves just like a volcano. So, when the angle is occludable, you are getting it on gonioscopy, it might be looking like a serene one, and anytime it can erupt. So, this is a quiet eye having occludable angle, and now I have not tackled it, so patient can go into angle closer glaucoma at any time. Yes, there is a chances only. It might not, but might, yes, he can develop. And we all know that occludable angles can progress to angle closer with a very high increase in intraocular pressure, ocular emergencies, irreversible damage to the optic nerve, iris, lens, endothelium, trabecular meshwork, and whatnot. And the mechanism is through pupillary block, which we all can alleviate by just doing only a simple laser peripheral iridotomy. And everyone, I think, has that capacity of doing these things. So then why not? I'll keep my eyes quiet. I got the eye quiet. I'll keep it quiet just by doing one LPI. It's as simple as that. What is the standard therapy for occludable angle? Everyone knows the cornerstone of prophylactic management of angle closure is LPI. This creates an alternate route for aqueous flow from PC to AC, allowing iris to move back, giving you a space for further surgery. IOP lowering effect of LPI can be profound in case of angle closure. So what the pressure, you got it 20, it might not be 20 as always. It can be only a snapshot in between. Patient might be getting high IOPs where they are not reporting you. And it significantly increased the angle width and the decrease the intraocular pressure in both angle closure as well as in occludable angles. Great minds think alike. and even greater minds like me, they also think like me. I would also like to follow the same path like laser PI to open up the anterior chamber angle, and after LPI, AC depth will also increase. We'll lower down the pressure if the circumstances arise, and then proceed for a planned cataract surgery in near future. I'm not telling I'm not going to tackle the lens. I will, but in a planned way, not in a hurried way. Patient is not coming to me with a grade 2 cataract, they get my cataract surgery done and give me the vision immediately tomorrow itself. So when I see that angle is occludable, I should tackle the angle first. So I just wonder why my partner is against of this small technical procedure which can make a wonder. And I also wonder why you always insist on cataract surgery and cataract surgery and cataract surgery when the problem is somewhere else. The patient is there with me, he will come to me only. So I will tackle him. He must have faced difficulty of doing cataract surgery in a small anterior chamber occludable angle, and must have faced the difficulty like steeper because of the steeper curvature of the anterior lens surface, narrower chamber angle, more anterior position ciliary bodies, more anteriorly placed lens and whatnot. There are a lot of literature. He was giving his topic and supporting that, and I can also give you literatures where it has been seen, where it has been written that LPI is the first thing you should do before going to cataract surgery. So I'm not quoting the details of it, but I have just underlined it for the time management. I'm not going detail of it. So these are the literature I have searched for it, and all are in favor of their LPI first, followed by cataract surgery. So my approach will also be the same, like rather than fast tackling the lens, I would prefer to address the angle first, relieving the pupillary block by doing LPI, deepen the angle width, prevent the angle crowding for future cataract surgery, reduce the pressure with or without AGM, and remove the cataract in a planned manner. Thank you. Thank you so much.
Who made your day, ma'am? Pinning him down just yet another time. So is it true, sir, that for all the issues that you face in life, you think cataract surgery is the solution?
Do you think so? You are the most prolific cataract surgeon returning at 9:30 at night.
It's not my wife who is saying that, sir. It's your... All right. Rebuttal time. What's that one question that I would like to put across to your opponent, sir?
The one question would be, what percentage of occludable angles move into acute angle closure attacks down the line?
You're taking a Viva?
No? You asked me to ask me one question.
I didn't say the question is not
And
valid.
also, I'd like to put a point. The angle can be occludable also means angle can also not be occludable. It's 50-50. What percentage goes into angle closure of these group of patients with occludable angles?
So, concising your thought, if all occludables do not transform into occluded, why treat all of them? Why give
Exactly.
them the load of an additional procedure?
Exactly.
Very valid point. Answer, ma'am.
Basically, beforehand, you cannot make which one will go for occludable angle, will go for angle closure, and which one will not. You cannot predict like that. Yes, the literature says 25%. So 25% of the patients having occludable angle can go in for angle closure glaucoma. But can you tell me this particular patient will go for angle closure or not? So why should I take a chance? When the patient came to me in a quiet eye, I should keep the eye quiet. He reported me, he or she, I don't know, he reported me in a quiet eye, so it's my business to keep that eye quiet and giving the best possible visual acuity according to my plan.
She has a point. 25% of the normal natural crystalline
I
lenses
think
are
it's 6%.
amenable to get cataract
It's
sometime in the future.
6%. It's not 25%.
Angle closure glaucoma, if it is a angle closure
Occludable
suspect,
angles moving into the
angle closure suspect goes to angle closure.
In 25% of the
Yeah.
cases.
6%.
6% of the cases. So,
Okay, if it's accepted 6%, then that is also fine. Why I cannot predict beforehand the way.
So you will laser 94% of the population just because of 6% can close into occludable angles. The laser machines selling out there downstairs will have a big boom industry, man.
But if this patient goes for this angle closer, who will take the responsibility?
Okay.
I'll
Who will
take-
take the responsibility?
I'll take.
He'll
I'll
take the
operate.
responsibility. Hasn't he taken responsibilities in life? How good is he in taking responsibilities in life? Okay, ma'am, your question to him.
My question is that if I do this patient's LPI, what's the harm? What's the harm I'm doing for
You are
this?
harming to 94% of the patients for nothing. you are you're moving the iris tissue for nothing.
No, that actually there has been a lot of policing on his end. He's attacking, but with a laugh and a smile, and his whole body is shaking. So that there is a policing effect to all of that. Thank you so much, both of you. It was a proper debate. We really enjoyed it, and thank you so much, ma'am and sir.
Thank
you.
for
Thank you so
agreeing,
much.
accepting. Any questions from the audience for any of them?
I know they say no, in marriage, people think that wonders happen. And after marriage, they wonder what happened. So I think that's what happens in House of Fire. Of course, I proclaim that there's no gender bias. I'll just go with science. Since we treat such cases, I think we should also give some take-home message. I think in this case, see, it's very well known that in the pathophysiology of angle closure spectrum, it is the lens which is the villain. Na bajegi baja, na rahegi na bajegi basuri. If you knock off the lens, this whole spectrum doesn't continue. So in this case, where it's an obvious PACS, it is not, if this were to be PAC, if there were to be synochial closure, then there would have been more debatable. Probably it would have tilted on your side. But I think the science is favoring you. Even though you're a helpless, hapless husband, still science is with you, sir.
But somehow, this same topic, thank you so much, sir. Thank you so much, ma'am. Somehow,
Thank you.
this topic in different flavors, this topic, KP sir, this topic in different flavors has been debated a lot of times, and I have watched a lot of debates based on this topic, of course, in different shapes and different colors and different sizes. Somehow, in this particular controversy, glaucomatologists would never ever agree to what you said. They would always say that LPI comes first.
So how do you expect to manage your angle closure attacks on the table, like in mid-dilated pupil, in this kind of eye? Because these eyes are then prone for malignant glaucoma as well on the table. So how do you expect to manage that?
So you are thinking it to be a malignant glaucoma on the table. So you are controlling the hypertension part of it. In these cases, usually you put up a mannitol preoperatively 2 hours before. In cases where there is a chances of angle closure, we always put a mannitol 100 ml before surgery. So that's obviously yes. I have to treat my patient. I have to what I'm meaning is we should not do laser PI for 100% of the cases when only 6% goes into the disease process.
I think with a GAT of 20, with a grade 2 cataract, if it's a mid-dilated pupil, I think the risk of malignant glaucoma without the other factors being there is the same perhaps for every case. So it's just that if the hypertension is there, then you should take your precautions to prevent that.
No gender bias, but I'm taking sir's side. As madam just pointed out about the mid-dilated pupil, I think it never goes into occlusion while it is dilating. It goes into occlusion when it is coming back. So while doing cataract surgery, it's dilating the pupil. So I don't think it would go into occlusion on table.
So that's what he said, that he might take mannitol as a prophylactic.
If there is an attack, that can always be punctured in. So very interesting to see two XY genotypes supporting sir, one XX genotype supporting ma'am, and all of them proclaiming we don't have a gender bias. All right, so going to situation number 2, and it's the Joshis from Hubli, Karnataka who will be fighting it out. Listen to the situation. Interesting one. No, but I'm not inviting him first. It's my prerogative, friend. There's a question that is being asked. Who understands and handles the extraocular muscles better? Who understands and handles the extraocular muscles better? The strabismologist, Deepti, says we handle them with care, compassion, and precision. The retinologist, Srinivas, says we handle more recti in one go in terms of numbers, and that's with increased frequency, so we understand how to handle the muscles much more than a strabismologist does. Let's hear them out. Deepti, it's you first. Start off. Of course. I properly and truly and fairly and squarely don't have a gender bias.
You are a strabismologist.
I am.
Yes.
I used to be.
I used to be, no, you are. Okay, so thank you, Anurag sir. This is the second time our house has been set on fire. So handling the ocular muscles, well, sir has already explained the situation. Strabismologist, we handle with care, compassion, whereas retina specialist says, we handle maximum number of muscles at a go, so I'm the pro. Disclaimer, none of these surgeries have been exactly done by him, but it has happened in the same OT. So this, huh?
Please listen to the disclaimer. None of the surgeries has been done by him.
No, we don't.
The first point, the first disclaimer.
You're not allowed to interrupt Srinivas.
Exactly, I got a mark there. So this is a saga of buccal surgery. So they are just trying to hook the muscle, but they're hooking the tenons. The first point said and done. We always hook the muscle under visualization because muscles can be close to very important structures like vortex vein, or it can be close to macula, and they continue hooking without visualization. So this is the first muscle of that eye. Now this is superior rectus. They forgot the oblique can be beside it. I don't know what they're hooking. They're again hooking. Oh God, again they missed it. And they tore something else over there. And now, okay, again they missed it. Number 2, chalo abhi to तीसरी बार में आ जाना चाहिए, आ गया. So they got the muzzle. So once they hooked it, they just pull it. Now I really cannot see where is the muzzle now. The muzzle has been pulled, the muzzle is shifted elsewhere, the eye itself is shifted, and when they're making, and now the muzzle ko latka diya hai. I'm really sorry to say, if any strabismologist sees a latkofying muzzle like this, they'll commit, they khud latak jate hai hum log, hamare liye to muzzle bhagwan hota hai, but this is a very bad way of handling it. Again the muzzle latka hua muzzle, and they're passing the band below it. Band baja diya. So muzzle or band, dono band hai abhi. So again, so this is the way the muzzle is being handled. So all said and done, there is no, I don't want audio nahi chahiye. Iska audio? Nahi, iska. Huh? I am not able to. Okay, so I don't know how to. So whenever they perform the buccal procedure, the vision may become 6/6 according to them. They feel, oh yes, it's awesome. But then the patient is still unhappy because his eye becomes googly-eyed. So this is what happens post the buccal surgery. So coming, I don't want the audio. Can you please put off the audio? यहाँ पे इस वीडियो में मुझे audio नहीं चाहिए. No, here I have muted it, but it's not. नहीं रुके. So this is one more case where actually the patient presented to me. Okay, so this is one more case where they presented to me with this large hypertropia. He said, I have already underwent a buccal procedure and I want a cosmetic surgery to be done. So I thought चलो superior rectus recess करके inferior rectus plicate कर दिया तो hypertropia ठीक हो जाएगा. अंदर गई, inferior rectus नहीं है, superior rectus नहीं है, medial rectus था, inferior oblique था, बाकी कोई muscle नहीं था. So I had to change my plan. I took inferior oblique and I put it in the place of inferior rectus to bring the eye down. और फिर जो एक और medial rectus था उसको भी डाला. Somehow I made the eye straight, but then I realized this patient, while removing the buccal, they had removed the muscles also along with it. So most of the muscles were torn. Other than just inferior oblique and medial rectus, भगवान ने मेरे लिए बचा के रखा था. उसका शादी था, शादी हो गया है. Yesterday, 2 days back, he called me up also and he told, thank you, madam. So this is the शादी होने के लिए, किसी और चीज़ के लिए नहीं. So this is the thing. So why this case is important to me? Because post-scleral buccal strabismus has given me my first international award as a best of the best video in World Society of Pediatric Ophthalmology and my best international hero, ophthalmic hero award also. So I always end up saying buccal surgery, it is owner's envy but a neighbor's pride. So ONIDA का tag mark है वो. We are surgeons say we can do better surgery for buccal or muzzle, but for muzzle we are the surgeon. Not we are, but we are the surgeon, not them. So I would like to conclude. He may be a master in retina. Matra Devo Bhava, Pitra Devo Bhava. For him, it is Retina Devo Bhava. But all said and done, Muzzle Devo Bhava is only for me and not for him. So I rest my case, sir.
He's quite deeply lost in thoughts. I don't know. But did you for a moment thank the VR people for giving you your first award in the international platform?
Partha sir also told me this. You should be thanking him for getting this award.
So he did the
No, but I
primary
put the
surgery?
disclaimer. It was not done by him.
Okay.
So I didn't thank
Srinivas, you hook muscles with your eyes closed? She said you do it not under visualization, but under buccalization.
Sir, can I?
No, you,
No, it looks like the house is completely biased.
okay,
So please allow us to make our points also, sir.
yes.
You are a referee, you are an umpire,
No,
you are the
I'm not.
anchor, you are the host, and
I'm
you
not.
can't be biased like this.
No, I am not biased. I'm just asking you a plaintive question. Do you hook the muscles under visualization or not?
Sir, I don't think this is even a question to be asked. When we say that with visualization you see better, you do better.
Okay.
That's our tagline in retina. If you don't see better, you cut the nerve, you cut the retina.
No,
You
the-
cut the muscle, you can
I think-
always bring
I
it
think-
back.
I
You
think
can
the
cut
point
the
she's trying-
retina, you can never bring it back. Once gone, is
The
gone
point she was
forever.
trying to make is, since the whole room is darkened, so people cannot know what you're looking at.
That's why,
The
sir.
nurses, I mean, the other people around or
And,
the eye.
and,
Okay, you
and we do it with the much better visualization. Much better visualization.
to the nurses,
In the sense that we use
to the, okay.
the 3D visualization, because they cause diplopia, we do under 3D visualization. So let me complete, sir.
Please, do.
Thank you very much.
Stage is yours.
Yeah. So thank you, Anurag sir, for this wonderful opportunity. And so let me go ahead. Please see this. So this video explains a lot of things. The strabismus surgeon, the strabismologist, they think that their goal is done by doing a muscle surgery. You saw the cameraman there? I'll repeat it again. Please, no, you can't, you're not supposed to talk again. Please, it's mine, this thing. You see there? Even Usain Bolt is just, he's having a heart attack, whether the cameraman is learning more faster than him. You see there? Our journey starts from there. From there, where they stop, we start from there. So for you, it might be the end, madam, but for us, it's just a warming up. We just start with the hooking of the muscle, and then starts the real surgery. You just end with the muscle, but we start with the muscle. Always remember, बड़े मियाँ ही होते हैं, छोटे मियाँ Subhanallah. Kids are always taught the roots are the most important things for the tree. She herself teaches to her daughter. What are the roots? What we need to do? Why is it important? Do you know? Where are the roots of your eye, madam? The roots of the eye is the retina. First think eye as a whole. I forgot to put one slide here where madam very nicely puts in all her presentation. Don't touch this, the blind patient touching an elephant. If you touch this, then he says it's a rope. If you touch this, he says it's a donkey. But see as a whole. So I want to tell it again to you, madam, on the stage. Please see the eye as a whole. Please don't say that I am good at muscle, I am good at muscle. Array, you are good at muscle, but you should think eye as a whole. The patient should have vision also, not just the muscle. With the muscle, what you can correct it? Can you correct the vision by the muscle? So muscles are just like the branches. They are just the part of the eye. They are not the soul and the heart of the eye. The heart of the eye lies in the retina. And if you have forgotten that, then we can have some more extra classes for you, madam. They talk about what is that TLC. Tender, love, care. All these things. I think it's the time to remove your mask, madam. So they all talk about this. We handle it so nice. So with so much tender, love, care, passion, compassion, what not all things. But what they do, in fact, we just try to hook the muscle. What we do? We just try to hook the muscle, tag the muscle. What they do? Just murdering the muscle. They just try to resect, resection. And sometimes, what happens? What they say? The famous book, don't pluck the flower. We don't pluck the flower. We just tag the muscles and release them without much harm. We don't pluck it. We just place it. Look at these articles. Strabismus following scleral buckling surgery. How much it is? 13.95%. And look at the efficacy of a strabismus surgery in adults. How much it is? 20% of failure. Any person, Tom, Dick and Harry sitting in this hall will know which is higher, 13% or 20%. It's proved in the meta-analysis that efficacy of a strabismus surgery in adults, 20% of adults do not achieve satisfactory alignment even after one procedure. Strabismus after retinal detachment surgery. Strabismus after retinal detachment surgery has been published that it is temporary in most of the cases. Restrictive problem, the irony, restrictive problems to strabismus surgery, it is very well published that may be responsible for some restriction in ocular motility that may cause new problems after surgery. Most of the time these restrictions are present as complex motility problem. There may be various reasons that can be excessive shortening, inadvertent capture of the extraocular muscles, transposition procedures, and the most challenging problem, the post-scar tissue adhesion formation. And she is telling that we do it very badly and then they end up in squint surgery. But let me show most of the cases where after doing squint surgery, we can't even pass the tagging. We can't even hook the muscle after they do the restrictive muscle surgeries. And what they talk about the muscle surgeries, sir. People always say, when you want to look at the girl, what they say, the parents and the in-laws, what they say, don't look at the face of the girl. The girl should have a good heart. Don't look at the face of the boy. The boy should always be good. He should have good heart. So this is what? The strabismologist in adults, they only are caring for the cosmetology. But retinologist saves vision. He gives vision. Please understand that. We all know what is the right choice. So PG students are always taught the aim is not only to do the surgery right, but to excel in handling the complications. A strabismologist ruptures the globe while taking a suture And who has to handle it? Retinologist. We only have to handle it. So what we say, don't worry, we are there to save you. But do they say it in that way? Do they say it in that way? They never say that. They say always you do that, you do this, you do that. But we have a big heart. You say, you cut the muscle, you rupture, you do whatever. We are here to save your eyes, save the vision of that patient. So complications after strabismus surgery, one prospective study found the scleral perforation of 5.1%. 5% of scleral perforation. Sir, the muscle stacking also was not done by me.
There was no muscle.
And not just suturing, perforation. Look at that, complications, even endophthalmitis has been reported. I thought about endophthalmitis only in cataract surgery and VR surgery. Even the literature says having endophthalmitis after squint surgery. Can you imagine, sir? It is out of the box phenomenon. Extraocular surgery causing intraocular infection, not just inflammation. It's also been reported in many papers. So what does the strabismologist cause? They say that they handle it badly and all those things, that it causes squint. But let me remind them, it also, what they do also causes allergic reaction. Look at the orbital cellulitis the patients might have, eyelid retraction, anterior segment ischemia, pyogenic granuloma, and God should save them if they have the lost or the slipped muscle. Most of the time, it's a vitreoretinal surgeon only who pick it up. It's all complicated. So, a Croatian proverb, a good horse has many flaws. A bad one has hardly any. So, retinologist tries to improve vision. He does not cut the muscle. Please remind you, he does not cut the muscle and he can handle all the complications. A humble confession. Scleral buckling surgery is done for gaining good visual acuity. But loss is strabismus due to muscle manipulation. Yes, I agree. In some cases it might have happened in the trainee's hand. But I showed you all the examples, how they cut the muscle and what problem, deeper problems it happens because of the muscle surgery. But even in spite of doing all these things, strabismus due to manipulation, इसीलिए रेटिना सर्जन्स को बोलते हैं हार के जीतने वाले को बाजीगर कहते हैं. Right? So, thank you very much for your patient listening. Thank you.
Yeah, you don't look at the face of a girl and try to look at the heart, but if you're not looking at the face of a girl and trying to look at the heart, it's not always considered polite, Srinivas. So, the beginning video, I just wanted to give you a clue. I mean, to everybody out here, the beginning video, he was not Usain Bolt. It was a marathon run, and it was completed in 26 minutes, of which the photographer ran actually the last 50 yards.
Yes.
Ask the photograph to run for 26 minutes and then come first. Then you would see who wins it, isn't it? So, bad comparison probably to start with. However, your question to him might be something else. Put it across.
No, I won't want to question. I don't want the question. But I think he didn't put forward most of the points clearly. He spoke about retina, heart, roots, trees, plants, jungle, forest. I don't know, somewhere in the middle.
I
No, 1
didn't say
minute.
about
This is my
jungle
1
and
minute.
forest.
This is my 1 minute. Please tell him.
Yes.
So,
Yes.
in the middle somewhere handling the muscle was lost. So,
Yes.
giving the vision, yes, I agree, vision is important. As an ophthalmologist, first thing we check is vision, but the muscles was lost. Number two, the presentation definitely is made by a fellow because he knows I don't cut the muscles. You have seen me, I plicated the muscles.
Yes.
I have stopped resecting the muscle,
Yes.
which everyone who has seen me knows, and I think Dr. Anurag also
I
knows.
think he might not have understood the difference between resection and plication.
Plication could be. So, and number three, प्रॉब्लम किसका नहीं होता है. ही इज टॉकिंग अबाउट एंड ऑफ आफ्टर रेटिना. ये तो रेटिना सर्जरी करते करते रेटिना कट करते हैं कितने बार. सो अरे रेटिना टुडे वी हैड यू पूर्ति रेटिना ने कट आग होइतो. आई हैव हर्ड दिस एट होम मेनी टाइम्स. सो व्हेन दे एवरीबॉडी हैज कॉम्प्लिकेशन. See, my disclaimer was very clear. He brought endophthalmitis in between, so now I'm taking out his thing. So complication hota hai, but I have not, touch wood, very few of them have end off after retinal surgery. And lost muscle, he asked me, lost muscle, I have the capacity to bring another muscle and replace in its place and bring back the normal vision. I have done that when there was no muscle in the eye. I will never ask a retina specialist to search the muzzle. Definitely no. I can rather ask an oculoplasty specialist, but not a retina specialist to search for the muzzles. So I would still say I am the Bazigar.
Your response, sir,
Sir,
if you are still in a state to do that.
sir, I told na, you are biased, sir. You are biased. So if you are biased, then we can't say anything, sir. But everybody knows. Everybody, the hall, everybody knows. I don't need to tell more about it. See, when they say that, yes, retina branches, tree, jungle, forest, Amazon forest, whatever forest or whatever it is. But please look at a patient as a whole. In a scientific part of view, I want to tell it. Please look at the patient as a whole. If there is, yes, there might be a mishandling of the muscles. I do not disagree with that. And squint learners, what they do? They hook it very nicely, they hold it very nicely. They don't lose the muscles at all, is it, when they do the learning? And what surgery was shown was done by one of our fellow. Yes, definitely, everybody. That means that any training would not have any objections or any complications or any mishandling in there. Cataract surgeries or anything. Take any surgery. Why just squint or retina surgery? Everybody will go through that stage of complication. But over the time, how do you evolve from that? How do you try to handle the complication is what makes it a master. So I would just like to say one word. Don't look at small things. Please look at a bigger picture. You should think of catering the society at large, not at individual muscle, pissle or anything. Please think of bigger picture. Thank you very much, sir.
Your question to your opponent, Srinivas.
Sir, no question.
Your question to him.
No question. It's already answered, sir.
Without any gender bias.
See, actually, strabismus and diplopia following a RD surgery, a retina surgery, is of no consequence because the vision they get after retina surgery is hardly any to cause a diplopia.
But KP sir has forgotten that nowadays what it was PL negative in those days and today we are making them ambulatory. We are decreasing the strength of the people in the blind school, sir. We have cases where we have treated children from the blind school. Ask one of our fellow who is now a competent surgeon at RIO Patna, who is sitting at the back, Dr. KP sir. She tries to save hundreds and hundreds of people there, and we have tried to bring people out of the blind school and try to make them lead a normal life. That is the vision of a retinal surgeon, sir.
The reason why you have made them ambulatory and they're leading a normal life is because they don't have diplopia. And why they don't have diplopia is there's not enough vision. But tell you what, ladies and gentlemen, whoever is there, this particular topic was actually quite significantly tilted and inclined towards the strabismologist. Srinivas did a phenomenal job to bring it around. We must give him that. It was amazing. I was not expecting this to give, get this color. All right, the last segment of today's session, which would be fought between the Sinhas, Shalav and Pallavi. Here is the situation for them. A 65-year-old gentleman, has a grade, Shalav, it will start with you, has a grade 2 cataract, a best corrected visual acuity of 20/50, a moderate NPDR, and a macular edema worth 200 microns. So, a 65-year-old gentleman. Sir, listen to the motion, please. 65-year-old gentleman with a grade 2 cataract, a BCVA of 20/50, a moderate NPDR, and a macular edema worth 200 microns. Your treatment of choice would be. Shalav says he'll give an anti-VJF injection first to flatten the macula and then do the cataract surgery. Pallavi disagrees, says she'll do the cataract surgery first, look at the macula, and then plan what would be the future course. Sharav, starting with you. No time constraint, 5 minutes. The stage is yours. Set it on fire.
Thank you. Thank you, Dr. Anurag. Is it working? Hello. Okay. So, unfortunately, while I was trying to upload my presentation, my hard disk crashed. Okay, after the 5th time, it was pulled out from one of the laptops. No. So, no. So both we had to make our presentations in a hurry, so it won't be as colorful as the previous presentations.
Who's we?
Both of us. I mean, she made her presentation, I made mine. Okay, so it won't be as colorful as, Srinivas. But don't hold your head here. You will still have a chance when you go back home. Well, again, you won't beat him up. Okay, so the case, as Dr. Anurag already mentioned, it's a 65-year-old man with a grade 2 cataract, BCVA 20 by 50, a moderate NPDR, and a macular edema of 200 microns. And my treatment choice, or any retinal person's treatment of choice, would be anti-VEGF first. Okay, so we know from literature very well that in patients with moderate to severe NPDR, CSME tends to persist or worsen after cataract surgery. And the outcome after cataract surgery has been reported to be worse in those with diabetic retinopathy. It's a very well-known fact. Everybody understands this. And CSME is the disease. Cataract is not the disease. Cataract is an aging phenomenon. So you have to treat the disease. The patient has come to you with poor vision. It may be 20 by 50, but if the patient has macular edema, which he does have, it's the CSME which is causing the decrease in the vision and not the cataract. So, is nuclear sclerosis grade 2 even worth operating? That's not going to give back the patient vision, because vision is 20 by 50. And with the recent generation IOLMaster 700, which measures the retinal thickness, will the biometry be accurate if you're doing cataract surgery first and this later? So it is better to stabilize the macula, give better post-op results, and happier patient. And look at the financial part of it. If you do cataract surgery first, you earn only once. But anti-VEGFs, you can earn multiple times. So I rest my case. Yeah, we had to make it in a hurry. Sorry.
Strong points, though. The last one being the strongest. So, Pallavi, he's saying that by doing the cataract surgery first, you're actually losing out on revenue. So, you're nodding to that? You're accepting that?
Hello. I always look at him and sing, पैसा पैसा करता है तू पैसे पी क्यों मरता है, every time, money. अरे हम ऐसे जगह में हैं जहाँ गरीब बेचारे गांव के पेशेंट्स आते हैं और उनको मोतियाबिंद करा के रोशनी लेनी होती है, उसके लिए वो कुछ भी पे करने को तैयार हैं. लेकिन जब आप उनको बोलो आँख में सुई केवल लगाने का इतना पैसा लगना है, तो दे विल डिसएग्री एंड दे विल गो बैक. सो
सिर्फ पैसे पे मरते हैं या आप भी मरते हैं?
So house is on fire, and The same case, a 65-year-old man has a grade 2 cataract, best corrected visual acuity 20/50, a moderate NPDR and a macular edema worth 200 microns. And obviously my treatment of choice would be cataract surgery first, look at the macula, and then plan. So let's discuss real life scenario. We have kept in this way because we are from a small state. And apart from Delhi, Chennai, Hyderabad, Mumbai, ये सारा जो average निकला है, how many eye surgeons are doing phaco? Around 10,000. How many eye surgeons do phaco and also they put intravitreal anti-VEGF? Almost 2,000 to 3,000. And how many practicing retina surgeons are there? 1,000 maybe, or 1,200, 1,300. So no, what are the odds patient will go to a referred retina surgeon when I asked him to go for the CME treatment? Very slim. So obviously, I don't want to lose my patient because patient has come to me as a comprehensive eye surgeon with expertise in phaco. He has trust in me और उसको उसके गांव वालों ने और अगल बगल के पड़ोस वालों ने भेजा है कि डॉक्टर पल्लवी तुम्हारा कैटरेक्ट निकाल देंगी, तुम्हें बहुत अच्छी रोशनी आ जाएगी. देन अगेन आई विल आस्क हिम, नहीं नहीं तुम्हें मैं ट्रीट नहीं करूँगी, यू गो टू माई हस्बैंड. वो पेशेंट सोचेगा वो इनका तो कमाने का तरीका है, पहले हस्बैंड कमाएगा फिर वाइफ कमाएगी. पेशेंट ऑलरेडी रनिंग फ्रॉम पिलर टू पोस्ट, अनदर इंजेक्शन. उसको शायद कहीं बताया गया इंजेक्शन लगेगा, वो भाग के मेरे पास आया क्योंकि सबने कहा नहीं नहीं वो बहुत ऑनेस्ट है, शी विल ट्रीट यू ऑनेस्टली. आई एम अगेन गोइंग टू टेल हिम एक इंजेक्शन और लगेगा, आप मेरे हस्बैंड के पास जाइए. पेशेंट विल डेफिनेटली गोइंग टू रन अवे. So in the era of modern cataract surgery, we are all doing phacoemulsification, minimum invasive cataract surgeries. Shalabh has put some studies saying that definitely there is going to be increase in DME after cataract surgery, but I disagree. क्योंकि practically मैंने बहुत कम देखा है. A well-done phacoemulsification poses no risk for increase in DME. We are putting good quality IOL and ensures optimal vision for patients. We are using pre and per-op NSAIDs. Nowadays, very good NSAIDs available. They take care of any minor inflammation per-operative or post-operative. Above all, by doing cataract surgery and clearing the media, I am making the work easier for my fellow retina surgeon or my husband because I am providing him a clear media to diagnose and treat better. He can have good image quality, imaging OCT FFA, and if at all he is planning to do laser, it's very easier to do laser in a clear media. There is no risk of injury to crystalline lens by intravitreal injection. We all know it's always safer to give intravitreal injections in pseudophakic eyes. So why not put an IOL first and then send the patient for an intravitreal injection? Let's face it, patient needs both cataract surgery and intravitreal anti-VEGF steroids, both eventually. But patient understand cataract surgery better than intravitreal injection. And especially in our scenario, if I'll say कि आपको पहले सुई लगेगा, वो बोलेगा आपने तो लिखा है बिना सुई का मोतियाबिंद ऑपरेशन करते हो, तो सुई क्यों लगवा रहे हो? They will not understand कि उनको इंट्राविट्रल इंजेक्शन क्यों दिया जा रहा है, उनके लिए आँख में सुई लगवाना है. और वो कहते हैं कि नहीं, अगर आप मेरा कैटरेक्ट कर लो, मैं अपना शुगर कंट्रोल कर लूँगा, मेरी आँख की रोशनी अपने आप ठीक हो जाएगी, जो शुगर से अप डाउन हो रही है. Because it's very difficult to counsel the kind of patient we get in our periphery, in our clinic, where most of the patients are coming from periphery or village. And obviously, I am not doing any harm by choosing cataract surgery first. Lately, it has to be done. He can go to some Tom, Dick and Harry, get the surgery, cataract surgery done, because I am refusing. So I will definitely do because I know कि it's good in my hand. It's best in my hands. And intravitreal injections are endless. You can see he'll put one intravitreal injection, then he'll repeat it, then he'll repeat it. He'll only, idea is to earn, earn and earn. But I want to give my patient a vision, a good quality vision first, and then think about money. So I'll remove his cataract first so that he is sure that जो मेरा मोतियाबिंद था वो तो निकल गया. अब अगर मुझे नहीं दिख रहा है तो मैं एक रेटिना सर्जन के पास जा सकता हूँ. But if I ask him to go first to a retina surgeon and get anti-VEGF done, he will definitely not agree with me. So intravitreal injections are endless and patients have to wait for good quality vision. How long? One injection, another injection. So first clear the media, remove the cataract out so the patient mind is settled that मेरा मोतियाबिंद तो निकल गया. अब अगर मुझे कोई प्रॉब्लम है तो वो मेरा रेटिना सर्जन देख सकता है. तो मैं बाद में फिर उसके पास जाऊंगा. He is more at a receiving end. Thank you so much.
Answer a simple question, Shalav, which is out of the block. Who amongst the two of you runs the household economy? So whatever you're earning, would it be fair to say that you're earning it for her?
No, it's not for her alone.
Not alone, but the household economy is run by the Home Minister, so
Yes.
whatever comes in goes to that account. And then one question to you. If you operate the cataract and then send the patient across to your husband, wouldn't the patient be saying that ये कमाने का अच्छा तरीका है?
It's like वो मेरे पास आया पहले. तो in spite of उसको पहले मैं भेजूँ शलभ के पास, मैं बोलूँगी नहीं, I'll treat you. But because you have something, because nowadays, oh, the slide is missing. I can explain well, I can counsel the patient well, and with preoperative investigation, proper investigation, we can document कि आप मेरे पास मोतियाबिंद के लिए आए हो, मैं honestly आपका मोतियाबिंद अच्छे से निकाल के good quality lens लगा दूंगी. लेकिन उसके बाद जो थोड़ा बहुत आपका डायबिटीज़ की वजह से प्रॉब्लम है, वो चूंकि एक रेटिना सर्जन ठीक कर सकता है, इसलिए you are open, either go to my surgeon or go to any other retina surgeon. But I will do my work first, so I'll remove the cataract and put a good IOL.
So your question to her in the rebuttal. No questions?
No questions. Because in our center, what we do is we do combined procedures. Any patient who comes with diabetic macular edema and has a cataract, we do it together.
Both together.
Do it together. She is.
No, but she said that the patient would then think that सुई लगवाना नहीं था, फिर सुई लगवा दिए, कुछ, there was something like that.
We show the patient the OCT also, that
Okay.
this is your normal OCT and this is what you have. So then the patient, of course, a picture speaks 1,000 words. That's why we show the OCT to all patients who would need a combined procedure. And patients generally accept a combined procedure.
You have any questions for him?
नहीं, he's
You're just returning the
already
favor by
looking
not
very, very sad and poor, so माफ कर देती
asking. He
हूँ मैं.
has accepted that he's lost it.
हाँ, हाँ.
The problem is, nahin, अरे I just lost over a year of data in my hard disk.
हाँ, अभी
Over a year of
2
data.
घंटे पहले.
All my videos and everything. So I'm going to get it, yeah.
चलो, I allow for the week, coming week.
I couldn't recover.
एक हफ्ता एंटी-वेजेफ लगा लो.
2 hard disk I couldn't recover, I even sent it to Mumbai and they couldn't.
All right, sir. So before wrapping it up, it's already 6:35, so I think we should all be leaving.
Okay, thank you.
We wrap it up, but science in what? Yeah, science is actually what he is saying. No, actually, see, if you stand firmly. So I think there's the one gray area in this whole motion was the macular thickness of 200 microns. It also varies from machine to machine. Because the TopCon OCT, a 200 would be considered normal. With the Heidelberg, it's more precise and the resolution is more, so 200 would be considered quite abnormally thick, is what my take is.
No. The present, this thing is we don't focus on the macular thickness now. Now we look into what are the activities of the fluid activity indicators. Say for example, if there is a subretinal fluid, if it's an intraretinal fluid, then those are the things where we need to give anti-VEGF and then go ahead with cataract surgery, or do both, or you can do both combined together. But when you just have a central macular thickness a little higher, with not having much of edema or the fluid activity, or say for example a hyperreflective foci or any of these, we look at the OCT biomarkers nowadays. So if these biomarkers permit to go ahead with the cataract without having much of fluid activity on the OCT, then we definitely ask them to go ahead with the cataract surgery and we'll handle it. Biomarkers, one is the intraretinal fluid and the most important is the subretinal fluid. But in cases of AMD and PCV, yeah. In cases of, yeah, I'm coming. So AMD and PCV, now we are looking into the sub-RPE fluid as well. If the sub-RPE fluid, now with the newer generation OCT and OCTA, we are able to detect the height of the sub-RPE fluid. That means the disease is still active beneath, which we are not able to see well. So in those cases, it's always better to go ahead with anti-VEGF first, subside the disease, and then go ahead with the cataract surgery. And as he explained, in case of chronic diseases, say for example, a very tall cystoid spaces of more than 100 microns, or if there is a hyperreflective foci which are more closer to the outer retinal layers, like nobody sits and counts nowadays, but that is not very relevant, but definitely these are the good biomarkers to use the steroids instead of the anti-VEGFs. But if you ask from a retina point of view, many people will say that first inject and then go ahead with cataract surgery. But as madam said, if it is ergonomics which is and the real life experience, real world experience of the patient, then in those cases it's better to do a combined. Because once you do a cataract surgery, you put a high-end lens and the edema increases. Again, it's going to be a losing situation for the patient. So in those cases, and if it becomes chronic, then you have to go ahead with the high-end steroids like Ozurdex or...
Point, Srinivas. I mean, they are practicing together, one of them in AS, one of them in PS. But say, for example, somebody like me, I'm a standalone private practitioner who only does cataracts, and I do have an OCT. I don't understand what biomarkers are. I don't know whether I'll be able to judge the fluid mechanics by looking at the OCT picture. What would you suggest generally in a patient like this? Because this is not a hugely thickened macula of 200 microns. It just is a little thickened than what you consider normal. And the patient has come to you for cataract. If you refer the patient, you have to refer him outside your premises. What would you do then? I mean, talking about the patient's perspective, only based on science, not really binding the patient to your poles.
No, if there is 200 to 250, we usually consider it as normal only. 200 to 250 microns of the retinal thickness is not considered as abnormal. Unless they have a epiretinal membrane or edema secondary to the traction of the epiretinal membrane. In those cases, definitely we would like them to have the anti-VEGF first, see their response, and then go ahead with the cataract surgery. Because even... This procedure is grade 2 only, and ECB is 25/50. Yeah.
In a standalone situation with a macular edema which is not much, you can also do cataract surgery along with PSC and that also works well. It does. You don't have to refer your patient and buy the PSC and
In the same sitting you can do it, but we have tried that, Shalabh bhai, but it doesn't work for the intraretinal fluid spaces. For the subretinal fluid, it might work. Only for the CMT, you don't even, you just do the cataract surgery and you ask them to follow it up with the retinal surgeons. That is much better if there is no fluid activity.
I think here there is no need for any anterior segment surgeon to hold back on giving an intravitreal injection. So if you see an edema on the OCT, there's nothing stopping an anterior segment surgeon giving an anti-VEGF along with the cataract surgery, or if an anti-VEGF is contraindicated, then a steroid along with the cataract surgery. It's not that they have to be sent to a VR surgeon to do it as a second procedure. It can be. Exactly, sir. That's exactly my point. That's exactly my point. That giving an intravitreal injection is like a first aid. that's what I'm trying to make a point of, sir. That it needs to be. No, what I'm trying to say. So everybody should be taught to give an intravitreal injection is my point.
But I consider that to be a domain of bounds, and I.
No, the recent consensus. No, the recent consensus is we usually don't suggest the cataract surgeons to go ahead with the anti-VEGF injection unless there is an emergency cases like endophthalmitis. But if there is anything related to AMD, if there is anything related to PCV, diabetic macular edema, then nowadays most of the retinal surgeons, it's not just because against anterior segment or posterior segment surgeons, but because they might understand a little more better about the things, so they advise them to send it back in a standalone. But in case of end of cases, then better not to stop if the patient takes 1 day time. In those cases, the anterior segment surgeon should know how to give an intravitreal injection, especially the antibiotics, and they should have a chart at their OT to just save the vision. Yeah, how to prepare.
All right. Final word. Time for the judgment hour. KP sir would tell us who nailed it, the wives or the husbands.
No gender bias. No, I think there is no question. Even the husbands took it like a walkover. I think it's the wives. XX. The X factor.